Hello, I'm Dr. John Kruse, and welcome to today's question and answer session. So we have about an hour. I can try to answer questions about the video released last week or this past week about ADHD in general, or broader questions on mental health. I see there's a bunch of questions that have already arrived, so I will summarize first the one video that was re-released or re-recorded and released, and then we'll jump into the question and answer. So that was Amantadine and ADHD. So Amantadine originally was one of our very first antiviral agents effective against influenza A. They found out that a group of Parkinson patients who were also being treated for influenza had an improvement in their Parkinsonian symptoms. So this was a standard medication for Parkinson treatment because it seemed to promote dopamine. It's only later that it doesn't seem to have direct dopamine effects. It's probably more through blocking glutamate channels. But there have been some small preliminary studies suggesting efficacy in ADHD, either through a direct or indirect dopamine activation, but more powerfully, or more interestingly, it also seems to have anti-inflammatory and other potential benefits. And given that some component of ADHD and many other mental health conditions seems to be tied into chronic inflammation, this may be helpful. So that's all I have to say about Amantadine, and I will just jump into the questions now. So hello, D-Boss again. And the question is whether I've seen guanfacine cause or exacerbate depression in patients. Is it a common or possible side effect of guanfacine? How about clonidine? And then related, is it safe to go cold turkey off of Intuniv guanfacine? The manufacturer did a trial involving kids and teens showing it's safe up to 4 milligrams a day, but the guidelines still say to taper. So I've certainly seen some people who felt sluggish or less energetic on guanfacine. Again, I've had much less direct experience with clonidine. I would not say I've seen anyone whose depression got worse. I'd say lower energy I've seen, but not changes in mood or changes in functioning. I mean, any possibility is, any reaction is possible. But it doesn't seem to be a common one to promote depression. And there have been a couple different studies. So again, the risk with particularly stopping clonidine, which originally is a blood pressure lowering medicine, is that some people do have rebound hypertension, and that means not just a return to the levels of elevated blood pressure the person had before they started, but shooting up at dangerously high levels acutely, and people have had strokes or other really serious consequences from clonidine with this, and the studies sort of directly tried to look for it. So it seems that guanfacine leaves the alpha-2 receptor more gradually, so it's less likely to provoke this rebound state. So the recommendation, particularly if you're at a higher level, is to probably taper it over a few days. And with Intuniv, which is an extended release product, that's probably even less crucial. So it's more on the verge of being overly cautious. So again, I cannot make specific medical recommendations because I don't have any of your medical history. I'd say I have seen many people who, because people with ADHD tend to forget or don't refill it in time or other problems. I've had numerous people who did stop abruptly and none of them have suffered problems. That's probably not a large enough sample size to declare how safe it is. But certainly clonidine, I would be very worried or wary about. Guanfacine, I think, allows greater latitude in that regard. Hello again, James Alexander, who asks, what are the possible physiological causes of a person's round-the-clock craving and overenthusiastic consumption of sweet and sour drinks and food like citrus fruits, kombucha, and lemonade? I don't know. So in terms of craving of specific foods, I don't know how much research there's been done. So there may be areas I'm not that familiar with. I'd say the biggest association or a body of research I'm familiar with is that there does seem to be some craving of sweets and carbohydrates connected with depression itself, and particularly connected with winter depression, seasonal depression. I mean, certainly people in certain deprivation states, so if there's certain, something like Addison's disease can affect salt balance because it's affecting the adrenal glands, and someone can crave salt in that situation. But other than specific nutritional deficiencies, um, I'm not even sure, again, how extensively I'm sure the food industry knows more about how we crave fat, sugars, salt. That's about all I can say there. Sorry. Hello, Dennis. Dennis asks, neurologically speaking, is it true that our habits are primarily governed by our endocannabinoid system? So that, yeah, I'll sort of defer on that. That one I will try to do more research. I would think that there's plenty of habits. I mean, almost anything can be a habit if you practice it enough. So I don't know that pervasively endocannabinoid system is reinforcing or influencing or modulating all of our habits. So I guess my question would be, what specific subset of habits may be more governed by our endocannabinoid system? And I don't know which subset of habits. So I'll just defer on that one. Hello, Tainer. Tainer started Amantadine 100 milligrams about a week and a half ago, and other than a reduced appetite and maybe a little less brain fog, feels like I'm not responding. Would modafinil be better? So again, I can't make specific recommendations. Amantadine at 100 is one of the standard dosages recommended, but my general approach is, if you're seeing some partial response, and it sounds like reduced appetite wasn't why you were taking it, that's more a side effect, but even a little less brain fog to me would be a good sign, particularly given that amantadine, drugs that work on inflammatory processes, the inflammatory process tends to be a slow chronic state rather than an acute situation. So even with some improvement after 10 days, my thought would be to give it a little more time. And usually my approach is, if you're seeing some partial effects and it's tolerable, it usually makes more sense to try more rather than jumping to another agent, or before you jump to another agent. So it's certainly possible that modafinil would have dramatically better and or different results. But if someone's already seeing some encouraging results on one medicine, my approach would be, again, to give it more time and maybe a greater dose. And my overall approach on dosing is the FDA recommendations, and FDA says this explicitly, are recommendations. They are not absolute, you should never go above this or below this. They are suggesting where most people are likely to respond, but with recognition, some people will need more and some people will need smaller doses. So rather than I'd say we should always be focusing on what is the response of the individual in terms of good effects and bad effects, rather than obsessing about whether this is a high or a low dose. So James Alexander is jumping back to last Q&A that I mentioned that there are only a few people who I felt comfortable prescribing Disoxin. What differentiated these patients from the rest? Good question, and this is probably more my hesitancy. It's a really simple answer. The only people I have on Disoxin are people who came to me on Disoxin, and some of them we went on and off and tried other agents, and my observation was also that they did not function as well on Adderall or Vyvanse as they did on the Disoxin. So I just think the risks are high enough that I wouldn't feel comfortable moving someone to it or suggesting they try it if they've had, and I do think that even these people that I was comfortable enough, there was some element of feeling they were overly dependent to a degree that I usually do not see with Adderall or other amphetamine products. So again, Disoxin is methamphetamine that is FDA approved, but rarely used, and many doctors don't even know that it's there and available in the US. Colleen asks about thoughts on minocycline. Saw it can be used off-label as an adjunct to schizophrenia drug therapy. Theoretically, has anti-inflammatory effects on the nervous system. So I'm aware of some of those studies. Doxycycline as well has been used off-label. I don't know specifically of its use in ADHD. There may be a few studies. I'm just not aware any more than what you've sort of mentioned. So Lisa Marie Williams asks, is smoking cannabis or better ADHD? For better? I'm not quite sure. I think it's just a typo. I think you're just asking, is smoking cannabis helpful for ADHD? So I do have a whole video on marijuana and ADHD. And again, in general, the symptoms that very, very consistently are both socially ascribed to people who smoke marijuana regularly and show up in studies of people smoking marijuana regularly, and that's less ability to concentrate, lower energy, lower motivation. Those on the surface are a horrible match for ADHD. They would seem to reinforce some of the executive function deficits there. And yet there at least is a subset of individuals with ADHD who consuming cannabis does seem to be what helps the thinking be more clear, and clear is the subjective word they often use. Smoking anything, smoking is bad for your lungs and heart and body. Are you usually consuming less smoking cannabis than routine cigarette smokers? Yes, but there are still negative health effects. So my preferred would be to find a non-smoking regimen to deliver cannabis if that's what really works for you. So Max Flynn says, hi. Some people get a stronger feeling of motivation and energy when first starting stimulants, which tends to fade away even at higher dosages. Is that a factor of tolerance and not retainable long term? So I do have a whole video on the honeymoon period. So this is not universal, but probably in at least half the patients I've worked with, and others note this as well, that the first days or weeks, and it's usually a pretty narrow, short period, the benefits from stimulant medication for ADHD are so great and wonderful and seem to surpass whatever the person can ever achieve in the future, even if they try higher dosages. So there's been speculation that some of this is physiologic intolerance, and there's been speculation that some of this is more psychological, that having, particularly if you've lived years as an adult with ADHD and had nothing that seemed to touch it or really improve it, and then suddenly you have something that works, that can be such a powerful experience that you may not be really paying attention to what you're still not paying attention to, and that with greater time, that psychological honeymoon effect may wear off. So I don't know of any rigorous studies trying to sort out what are the factors in having that honeymoon period and why some people experience that and others don't. And part of it is difficulty is that is tied to one of the most pervasive problems in all of psychiatric research, and that is we have really lousy measures for measuring severity of symptoms. Lots of bright people spent time on it. It's not that we have nothing. It's not that it's all garbage, but sort of degree of improvement winds up intertwined with so much subjectivity. So I'll leave that at that. James Alexander asks, why do I discourage people from seeking out Disoxin as a treatment for ADHD beyond the elevated addiction psychosis risk relative to other stimulants? So my resistance is entirely based on that addiction psychosis risk. So we have very poor quantitative studies as to what is actually the addiction rate. A little more evidence. I mean, the rate of psychosis with amphetamine-based products seems to be about 1 out of 500 or 600 individuals who are on. And it's, I would say, unquestionably higher. What's particularly bad is that studies of medication-induced psychosis, particularly stimulant-induced psychosis, indicate that if you look at these people after a single episode, 15 to 20 years later, at least 20% of them are in a chronic schizophrenic state. So to take someone who was dealing, and I'll say this only with ADHD, and not that ADHD can be impairing and fatal, but to put them in a chronic psychotic state is horrible. So, and 1 out of 500, 600 isn't that rare for amphetamine, and it's undoubtedly higher. And right now, other than having a specific past history of psychosis or family history of psychosis, I'm not aware of anything that would tip us off as to who is most at risk. That to me is really bad outcome. Addiction, I'd say, still gets far more attention than psychosis, and it's often blurred with it. They're, I would argue, completely distinguishable and separable conditions, so you can certainly have both. Most of the studies indicate 2 to 3% addiction rate to that stimulant for people on amphetamine-based products, and again, higher with Disoxin, methamphetamine. A few out of 100 is not, it's uncommon, that's not even rare. So to my mind, we can get into issues of informed consent and autonomy and usually this is going to sound horrible and I don't have a good way of wording it, but I think, a little more tolerant than other doctors in terms of providing information. And if you really think this risk is worth it for you, then go ahead, even though I might not think it's a particularly good option. But this is one place where it crosses my line that I'm concerned enough that it's not a good option, that even if you do, I'm not willing to go there prescribing. So Max has forwarded a question from, I guess it's another one from Significant Club. Is there a relationship between autism and epilepsy? I've seen a lot of people have both. Is it because of problems in the corpus callosum? So I don't have the numbers in front of me, but as far as I am aware, yes, having autism makes you more likely than the general population to have epilepsy. If you have epilepsy, chronic seizure condition, are you more likely to have autism? I think the association goes both ways. And I would not think that most of it is necessarily problems with the corpus callosum. So the corpus callosum is a major white matter, the fibers, axon fibers, myelinated fibers connecting the two hemispheres of the brain. Certainly some cases much more in the past, the corpus callosum would be divided to, if there was one lobe of the brain that was an epileptic trigger focus and was causing seizures throughout the brain, and that could isolate it. But I don't, to my knowledge, problems with the corpus callosum aren't particularly closely tied to autism or epilepsy itself. James Alexander says, drug addicts often say you will never reach anything as good as your first high, and ADHD patients online frequently claim the same thing about the first time taking stimulant medication. Does this mean that even one dose of stimulant medication can cause permanent downregulation of receptors or whatever other brain changes are producing this effect? Do we have any reason to believe that short-term use of psychiatric medications can cause permanent brain changes? And I'm interrupting that. I'll answer that, but Max did provide the link to the marijuana and ADHD video. So I would actually jump a little bit away from the addiction, and I would say the psychosis evidence would show that short-term psychiatric medications can, in some cases, cause permanent brain changes. So although many of the experts on ADHD say, they've said for years, amphetamine-induced psychosis is really, really rare. It's only going to happen if you're at massive doses for a long period of time. There's very weak evidence that higher doses may increase the risk. I've certainly seen it in people who were not on amphetamines for a long period of time, so it can show up quickly. It can also take a long time to show up in other people, but it can show up very quickly. So that's showing that within a very short term of exposure, you are causing, at least in some segment of people. What that doesn't tell us is how pervasive or how likely short-term exposure is to cause permanent brain changes. From what I can see or guess, the propensity, and this is from marijuana psychosis and others, that propensity to psychosis is probably under some genetic control, and most people aren't particularly at high risk, whereas probably a greater proportion of people are at risk for triggering issues with addiction circuitry. So it's plausible to me, but I don't think definitively shown at all, that yes, very short-term exposure, 1 or 2 episodes, can rewire reward circuitry in the brain. And that could predispose to addictive processes or be a contributor to moving further along the process of addictives. So hello again, Sleiman Bisharat. I had any patients who take lamotrigine alongside stimulants. I'm wondering if lamotrigine can help with the anxiety or depression that sometimes comes with stimulant use. So lamotrigine, Lamictal is the brand name in the US, originally an anti-seizure medicine, it's also been approved as a mood stabilizer for bipolar disorder. And particularly among the mood stabilizers, it's much more documentation supporting that it has an antidepressant effect than an anti-manic effect. In the US, it's being used moderately frequently for treating unipolar depression. And to my knowledge, there are very few studies. I mean, the FDA does not support it for that indication. Doesn't mean it doesn't work. I've also not come across that many studies looking at it in the setting of unipolar depression, even though, again, it is being used that way. So in my personal experience, I can't think of anyone where I've added lamotrigine just to deal with depression while they're already on a stimulant. I've certainly had some people who are on the combination of the two for different reasons. I've not been particularly, so I fairly often have used lamotrigine in bipolar depression. I've less commonly seen it be helpful for anxiety. So that's about what I can say there from my own experience and what I know from the literature. So Jatin Raghav, hello, and is referring back to my Huberman podcast. And they tried armodafinil today for the first time in my life. Here in India, it's easily available over the counter by the name of Wake Alert. That's a simple, pretty clear name. So I hope you get positive results and no negative results. And certainly you're welcome to describe whatever experience you have on the comment section in my video on modafinil and armodafinil. So again, armodafinil, in the US, it's called Nuvigil. It's also been called the non-stimulant stimulant. Whether it's working primarily through orexin systems or dopamine systems is not clear, but usually seems to avoid most of the serious, either addictive and or psychosis risks of full-blown stimulants. Most people don't feel too revved up, but they do feel more alert, which would fit with actions on the orexin alerting system rather than the sympathetic revving up system. Several studies documenting it works for ADHD, but not ever approved by the FDA in the US for ADHD. So Slayman asks, have I any patients who have used baclofen long-term to manage stimulant-induced anxiety? And how safe is it to take baclofen over an extended period? So baclofen is often described as a muscle relaxant. There was a lot of interest because a prominent physician, I think he was French, was promoting it widely, maybe wildly and widely, for alcohol abuse. The few studies I've seen didn't seem to indicate it was that powerfully helpful in that setting, although some individuals may be helped. So one is it's a sedative medication, and I'd say usually it's better to, if you're feeling too revved up, too anxious from your stimulant, it's usually, this is again, general approach or philosophy, better to reduce the dose rather than add something on to try to counter those effects, because then you're sort of bouncing from an upper to a downer simplistically. So yeah, I think there are dangers and risks to long-term downer, sedative, muscle relaxant use. So I would not be a big fan of using that for anxiety. And in general, my thought would be, in terms of safety record, SSRIs or buspirone are where I usually look for anxiety relief. And again, if it's stimulant induced, my approach is reduce the stimulant. That's a sign you're on too much or too revved up. So thanks, Max, for providing the links to the honeymoon period. So Jatin, and again, I'm sorry if I'm butchering your name, is 32 years old and hasn't been on any other medication for ADHD other than a nootropic called Ultrabrain, and feels that the armodafinil is working well for him. So good to hear that, and I hope it continues to work. So Max is getting back to my comment, I think, about the person who seemed overly dependent. How do I differentiate between someone needing their stimulants to function and being dependent on them? Is there even a distinction there? So the ostensible distinction, whether it's a real one, is that, and this might seem simplistic or silly, is that someone who's just needing it to function, if you take away the stimulant, they are not functioning, but they're not necessarily craving. I mean, they're able to observe, okay, I'm not doing this task as well. I'm not able to attend to this. I'm not starting this or initiating this. But the dependency for me involves some element of craving, needing, not just a loss of function, but a feeling that this was essential to their mood as well as their executive functioning. Maybe that's, and so, yeah, so I would say requiring it and dependency are different. And yes, part of it is English is the meaning of dependent has a narrower term, I would say, in medicine and particularly mental health medicine than it does in general English usage, because dependent could just mean you require it, but dependency requires some amount of craving, desire for the substance beyond just its functional value. So James Alexander asks, can I explain how I reconcile my observation that medications like Strattera appear to work immediately with my theoretical knowledge that these medications take time to induce brain changes? Well, so that's a simple answer. So one type of brain change you can induce is having a greater release or greater amount of substance available in the synaptic cleft because you've blocked its reuptake. Those changes happen within minutes to hours. So stimulants block the reuptake of norepinephrine and dopamine, particularly Adderall. Amphetamine-based products actually induce a greater release, a greater amount to be released. That is an immediate, direct neurochemical effect that's happening right away, and that correlates with changes in brain function right away. Now, can a drug like Strattera have both immediate and slower, more gradual effects? Absolutely. And something, maybe it's more clear with the SSRIs. The SSRIs have acute, immediate effects on making more serotonin available, or the same amount of serotonin available for a longer period of time. Side effects to serotonin drugs, sexual side effects, lethargy, nausea, all those can happen immediately on the time scale of what we're seeing going on at the serotonin reuptake receptors. On the other hand, benefits in terms of reduced mood or reduced anxiety with SSRIs almost always happen slowly over the course of many days, of 10 to 20 days is usually when we first start seeing those good effects. And that to me is reasonable because the immediate effect on serotonin is the one that alleviates mood or anxiety issues. So I don't know if that answered your question, and I'm happy to circle back if it didn't. Sorry. So many questions coming in, I'm getting behind. So I don't. So I guess the second part is what's my current theory in respect to how these medications actually work, and I'm not sure which if these was. So again, I think my evidence is most of the benefit from Strattera is, if you get a benefit, is from norepinephrine reuptake inhibition, which is again making more norepinephrine available or making the same amount available for a longer time, but boosting the signal at the downstream receiving receptors. And I think when bupropion works that way for ADHD, it's having some reuptake action in norepinephrine and dopamine when, and I think our medication that works slowly, like guanfacine, are having indirect effects. So I'm not, yeah, if I haven't answered that well enough, ask me what part I'm not being clear about. So Sleiman asks, I've read that around 50% of people eventually stop taking ADHD medication long term. Do you think that's mainly due to side effects becoming intolerable over time, or are there other common reasons? So I think the really important figure there is what population are you looking at, in particular the age of the people. So it's really common for kids, adolescents, even college age students to take stimulants for some period of time and stop taking them. And I'd say it's far less common in my experience, and at least in the other clinicians I've worked with, that most adults who find that they work continue taking them. Not all. So there's certainly people who essentially find ways to structure their life better or make greater use of CBT skills for managing ADHD symptoms who get off their medications. So I'd say my approach when you're treating or dosing is you don't continue, or you don't put people on doses where they're having lots of side effects. That's a sign that there's too much, or the drug itself is not a good fit. So in that respect, most of these, it's not that stimulants become intolerable for adults over time, usually. And again, psychosis and or addiction can happen over time, but that would be a small percentage of individuals, not a large percentage of individuals. So thanks, Max, for providing the link to the modafinil and ADHD link. And James Alexander says, in the past, I've mentioned having known of tragic cases of patients with insufficiently treated, undertreated ADHD caused their deaths. Can I tell of some of these stories? So there's patient confidentiality issues. So the difficulty is I should not be providing enough detail for people to recognize these individuals. But then if I'm manufacturing details, how true or valid or meaningful is it as an example? So, the two that I've talked most about, and one I call her Lucy, and I think this is, I don't know which details, whether it's regarding the incidents around her death or the longer term. So I'll tell you, since I've written about this before and I'm in other venues. So Lucy, I first met, I worked for years, or did medication management for a psychotherapy clinic in San Francisco. This was a low-fee clinic focused on psychotherapy. They tried to screen out patients who would need medications, but depending on how good their screening was, somewhere between 5 to 10% of their patients did need medications or were already on medications. So I saw those patients, and for a span of years, we did it in a small group format. So Lucy came to me on the first session. She came in ostensibly for depression, but her ADHD symptoms were so rampant, interrupting herself, going off on tangents, getting agitated and acceptable and loud, highly distracted. She's clearly intelligent, She described losing multiple jobs because of outbursts at work and conflict with her coworkers. And on the evaluation, I said that, in addition to depression, there seems to be a significant element of ADHD. She adamantly denied that she had ADHD symptoms, even when we reviewed them and they matched. When she came back for a follow-up, though, she acknowledged that she had been diagnosed as a kid with ADHD and been on Ritalin, and that was such a horrible experience that she sort of wanted to deny the existence of her ADHD since then. Over the course of time in the group, she was not willing to go back on any stimulants, but she had a decent response to duloxetine, Cymbalta, both for her mood and for ADHD. Certainly didn't resolve all symptoms. She was able to find a more stable job. She was able to extricate herself from a difficult relationship. She actually was doing pretty well professionally and personally and moved from California to a different state. So stopped being my patient in this different state. She had both career and romantic disasters. At least twice tried suicide, once by driving off a small bridge. And doctors there contacted me at that time, and I provided them information with consent. Anyway, seemed to be doing okay for a while, and then had another personal disaster in her life, came back to the San Francisco area. I wasn't aware of this until she called from the hospital. This was a hospital within San Francisco, and she was saying, they're telling me I'm manic and they're giving me sedating antipsychotic medication. And I talked to the doctor there, and I said, no, every day, and by this time I had known her more than, I think, 15 years, more than a decade at least, and seen her on dozens of occasions. And I said, every day of her life, this Lucy is talking a mile a minute, jumping from topic to topic, florid emotions. This is not a manic episode. This is her ADHD, which is at the severe end of the spectrum, but it's ADHD. And they essentially said, no, this is mania. This is mania. She's also not sleeping much. Therefore, it's mania. There's nothing grandiose about what she was saying. There was nothing. Again, this is not a departure from her baseline. There is nothing bizarre about her. I mean, most people, particularly when they're that revved up, are at least somewhat delusional, some floridly delusional, but there was none of those aspects of mania. And they essentially gave her enough, and I'm not remembering whether it was Seroquel or quetiapine or olanzapine, one of the fairly sedating, mood stabilizing antipsychotic agents, said that she was well enough to be discharged. And the next thing I heard was a call from her sister saying that Lucy had jumped off the Golden Gate Bridge, that she had been despairing at not being understood or treated properly, and that she was not going to get any real help in this world, and killed herself. So again, the moral of the story there is that severe ADHD can look like mania, that the history of someone is really important, that inpatient doctors should get much more information about ADHD, and that they should listen to someone when they describe what their history has been, or when external corroborating sources document that this is the status quo for an individual. So, and that, there are other cases. So if there's, I'd say particularly if there's a specific question involved, rather than just, I don't want to, we shouldn't be voyeuristic, but I think part of the point of sharing anecdotes is that they do make an impression on people. They do change opinions much more strongly than dry statistics and facts. So I think they are a useful tool, but we need to be really careful because these are human lives. So Beth L. M. Hello again. Is there a correlation between guanfacine dose and reduction of ADHD symptoms, as in the higher the dose, the lower the symptoms, or is the drug acting more like a gateway to neural changes that begin to take effect and increase irrespective of the drug dose the longer you are on it? So part of this is hard to tease out because so many people, both the patient and the doctor's expectation is that for most substances, it's not a threshold that's a linear or maybe exponential, but an increasing relationship, you take more, you see more of an effect. So it's hard to know whether, and I'll put this more on the patient subjects, that it's their experience or their expectations. But I would say I've had many people who did report showing that they had mild or minimal benefit from guanfacine, even sitting at it a few months, at 1 or 2 who did see more of an effect at 3 or 4. So I've at least seen people who did seem to have some dose response relationship to guanfacine in the 1 to 4 range. But again, particularly given that it's such a slow acting medication and given expectations that we might anticipate a dose response curve, I'd say that the better way to study that would be to assign people to a randomly do a random control study and decide that some people are going to hit 1, some are going to hit 2, 3, or 4, and see if we see a greater degree of reduction in ADHD symptoms in the different groups and a different percentage of people responding. Diane comments that 20 years ago, she was misdiagnosed with bipolar disorder and been on Lamictal and an antipsychotic ever since. I was recently diagnosed with ADHD, taking Fotolim, and doctors weaning her off the lorazepam. So the question is, does lorazepam cancel out the dopamine effects of Fotolim? So in my video on antipsychotics and ADHD, it's a great question because it's often sort of posed that schizophrenia is from too much dopamine and we need to block it, and ADHD is too little dopamine and we need to boost it, and that these antipsychotics are working one way and the ADHD drugs are working on a different way on dopamine systems. So separate from the fact that there are some distinct dopamine different circuits that might respond differently. Some, and Stephen Stahl probably is one of the best writers and illustrators about this, would suggest that we're being too simplistic on what's dopamine boosting and what's dopamine blocking. And yes, the immediate direct effect of many of our antipsychotics is to block dopamine receptors, but particularly drugs like Abilify are clearly much more dopamine modulators, and there's differences between the acute phasic responses of dopamine receptors and the tonic sort of, so the phasic is how big a burst you're getting in response to a specific stimuli, and the tonic is more the low-grade background release rate of release, and that both of these products, and I'm making big generalizations, may be doing more to modulate and keep tonic levels in a certain reasonable physiologic range. So the simplistic answer is yes, it's possible lorazepam is blocking some of the effects of the Fotolim, and you'll see more as you get off of it, but it may be a more complex dopamine regulatory role rather than just blocking there. So Sleiman has this reduced doses of either Vyvanse or Adderall and still has anxiety 2 to 3 hours after taking it, but lower doses don't seem to be effective, I guess, for ADHD. Again, my general thought on a similar situation would be to think more in terms of buspirone or an SSRI and or cognitive behavioral therapy to focus on the anxiety. So in situations somewhat similar on the surface, and I don't know if they're similar in reality, there are real physiologic effects within an hour or two of someone taking stimulant medication, and particularly in terms of activating the sympathetic nervous system. But I think often then the body, particularly if there's reason someone's primed for panic or anxiety, that their body is interpreting, oh my God, I'm revved up, and that actually creates a panic feedback circuit. So I've seen CBT be very effective in teaching a body, okay, I can feel the drug kicking in, and that doesn't have to be moving in an anxious direction. It can just be in an activated direction. So yeah, so Diane, good luck moving forward, and I hope that you find a combination of medications or just a single medication that more actually targets what you're dealing with. So I think it says, Luke asks, sorry, I'm jumping around. So Luke asks, does having ADHD make someone more prone to porn addiction? So I think there is some, I know there's survey research on people with ADHD, so in terms of sexual functioning, so more likely to start sexual activity at an early age, probably due to impulsivity, more likely to have multiple partners, more likely to have problematic is defined in terms of exposure to sexually transmitted diseases and others, and addiction processes in general seem to be more prevalent among the ADHD population. How much of that is specific biochemistry that makes someone prone to both addiction and ADHD, or whether it's the specific behaviors of ADHD making someone prone to addiction. And we know that both inattentive and hyperactive impulsive symptoms, both are correlated. So impulsive and inattentive both can increase your risk of developing an addictive process. And I do think the evidence is pretty robust that addictive behaviors like pornography, gambling, probably extensive gaming have strong parallels and probably similar circuitry to substance abuse, substance addiction. So I'm only seeing part of a question from James Alexander, asking what could possibly explain this, but some of the other previous was retracted. So thanks, Max, for bringing the link for ADHD Kills People. And Luke asks, am I familiar with the YouTuber Dr. Russell Barkley? So I would identify Dr. Russell Barkley as one of the preeminent researchers and public messengers about ADHD in children and adults for decades. So it's only more recently he's become a successful YouTuber as well. So I know who he is. I respect and value his work. He's also been willing to say things that some others in the field don't, like questioning our reliance on neuropsych testing for diagnosing ADHD. And he strongly takes a stance that there's very little evidence that it is likely to be useful for most individuals. On the other hand, I watch almost no podcasts or YouTube or other things. So I've only seen one or two of his actual videos. So I'm not familiar in that way of having watched a lot of what he does. Sleiman asks, do you use Wellbutrin XL or IR for your ADHD patients? Is there a difference? So I do have a video on Wellbutrin, and almost always I use Wellbutrin SR. So 3 formulations: immediate release, sustained release, extended long release. And there's a huge misconception, and it's really strongly embedded among the pharmacist world and in almost everything written about. When it first came out, Wellbutrin immediate release, most of it's dumped into the body in about a 4 or 5 hour period. It was recommended as a 3 times a day medication for depression. When its patent was about to expire, they developed Wellbutrin SR, sustained release. Drug is being delivered over about a 12-hour period and then tapering off. There's this slight bump at the beginning, so it's not a steady rate throughout of release, but an initial bump and then fairly steady. And when that patent and SR was approved as a twice-a-day drug, so most people were taking a dose at bedtime. One of Wellbutrin's commonest side effects is to disrupt sleep, although many people can tolerate it at bedtime, many can't. But there's good evidence that both the immediate release and the sustained release are perfectly adequate antidepressants once a day. So when the SR was about to lose its patent, they came up with XL. So the XL used an osmotic technology, so extremely steady rate of release, but its actual release profile is very similar to the SR. So there's not an initial bump at the beginning. It may last a little longer at the end of the day. It is not continuously releasing medication for 24 hours, despite what almost every pharmacist in the world will tell you. So the confusion came about because the SR was approved by the FDA as a twice-a-day medication. The XL was approved as a once-a-day medication. And in the pharmacy systems, that got translated completely inaccurately to one's a 12-hour release and one's a 24-hour release. Not true. So why I like the SR, one is the slow release mechanism is the matrix. The drug is locked in. You can break the pill in half and it's still a slow release medication. If you break the XL, the brand name XL is an osmotic release, you've destroyed the whole slow release mechanism. You cannot split the pills. And again, 2 is many people with ADHD actually prefer or need or want a little more of a bump early in the first few hours. And there's a little more of a bump at the beginning with the SR than with the XL. There are some people, the XL lasts a little too long. So that's how I would describe the differences. So WD, and I can't even YAM, can unknown gluten sensitivity and consuming a diet high in gluten cause ADHD-like symptoms and depression and anxiety. So, celiac disease, fully documented, clear, robust immune reaction to gluten can present as a variety of symptoms. It's not the most common, but certainly there can be some overlap with ADHD symptoms. There certainly can be some mood symptoms. So it's certainly possible. There is almost certainly a broader range of people who have some immune overactivation or response to certain, and it can be other. Gluten is one class of proteins, so there's several proteins within that family. So it's certainly plausible. I would say it's not, in my experience, a particularly common cause of someone reporting or coming to the office for evaluation of ADHD symptoms. And I'm seeing I'm getting close to the end of time, so I'll try to. So James Alexander, I'll probably defer that to the next time because I'm. I'll give the short answer. When I run into ADHD deniers, one I think is that there's a tendency towards generational differences. So I'm in my, I'll still say early 60s. When I went through training, there was not at a well-respected psychiatry residency, there was not a single mention ADHD could exist in adults. So and I'm still close to the average age of a psychiatrist. So lots of, compared to other medical specialties, lots of people stay in psychiatry. It's less demanding on the body. Anyway, anyone my age, if they know about ADHD existing in adults, it's because they taught themselves after their official training was over. So, yes, I have argued with ADHD denying colleagues. My experience is it's sort of like arguing in the political realm these days, that people tend to only look at the data that supports their cause and not look at others. I mean, there's one fairly prominent ADHD denying Gamani. I might be butchering his name. He claims or thinks it's all depression and affective disorders, and it's like, have you really even talked to anyone with ADHD? Because yes, there can be overlap with depression, and depression can cause some executive function disorders, but there's a substantial proportion of people with ADHD who are not showing any signs whatsoever of depression or anxiety and are showing pure ADHD. Anyway, yeah, maybe it's not worth going into that longer, but that's where I would start. So thanks, Diane, for asking questions. So Max, thanks, provided the link to the antipsychotics and ADHD video. I'll just try to race through what's left. Mark asks, I've taken Dexedrine for years, but since becoming diabetic, it causes chest pain, as does Vyvanse. Switching to Wellbutrin, hoping it will work, but I'm very scared that it might not. So, I mean, chest pain can be through physical reasons and psychological reasons, and both. But being scared is a risk factor itself for having chest pain. So I would again think, and again, I can't make specific non-medication recommendations, but in a scenario like this, I would think of using cyclic sighing and other breathing and other relaxation techniques to sort of calm your body, scan your body, but respond to your body as this is a sensation and not necessarily a sign of danger. If the chest pain is clearly associated, it's probably worth getting an EKG or maybe even a full cardiac workup to. And the biggest reason might be just to reassure that there isn't a dangerous situation going on here, or to detect if there is one. So I'd say, although in general, amphetamine-based products do help to a greater extent and help a greater proportion of people with ADHD, there are certainly many people who are able to function well with the assistance of either methylphenidate-based stimulants or other non-stimulants, and some who even get a better effect. So Jayton says, what's the recommended dose for armodafinil in a 30-year-old, 32-year-old healthy male? And again, one of my pet themes is don't worry about recommended doses. Work on what works for you. That being said, in the US, the recommended range of dosages for modafinil, which is 100 to 400, and for armodafinil, it's something like 50 to 250 milligrams. So that's where I'll leave that. Thanks, Max. Max is asking if people are familiar with the TikToker. So I'm not really on TikTok. Max has set up an account. Dr. John Kruse, that has a nice ring to it. Interestingly, living in San Francisco in the middle of the gay neighborhood, I was often told that Dr. John Kruse was a good porn name. Won't go there. But so, have you ever heard or treated someone yourself for ADHD who ended up not having it? If so, what was the outcome and what kind of symptoms did the person show when treated with stimulants? I mean, some people have said I've seen ADHD where others haven't seen it before. I'd say I'm fairly convinced that it was real and legitimate and responded in ways we'd expect a medication. I have only had one patient who came to me with an ADHD diagnosis. I believed it was accurate. I continued treating with him for it. He then went into an addiction program, which was a program that didn't believe in the existence of ADHD and told him he didn't have ADHD. He only had addictions. Even in our discussions about that, and I only saw him once or twice after he left that addiction program, to me, he was still displaying clear, robust symptoms of ADHD. So I think I do see it where others hadn't recognized it, but I do think I'm on the careful side in terms of ascertaining that it's there. I mean, even people a couple other things to remember, ADHD exists on a spectrum. So people may not have full clinical diagnosable ADHD, but may well have ADHD symptoms that respond to stimulants. And even people who aren't on the ADHD spectrum, stimulants we know can improve mood, they can improve reaction time, they do have effects on, and I do have a video on stimulants in people who don't have ADHD. So James Alexander, I'm just going to pass on. He's asking, how long does it take testosterone therapy to start permanently desensitizing the Leydig cells and testicles? So I just don't know what the physiologic actual time course is and how much individual variability there is. So Max is forwarding question from Reddit by Designer Study. Have I read the book, The 48 Laws of Power by Robert Greene? It suggests a right brain way of understanding humans full of nuances, contradictions, and exceptions. So I am not familiar with that book. I'm writing it down. So I will check it out. Again, Ian McGilchrist is who's an incredibly dense, I would say difficult writer to read through, but worthwhile. So he's the one who's written most about left brain, right brain, but I will try to check this out. So thanks, Max, providing the link to the video on depression and ADHD, on cyclic sighing. And thank you all for being here today, and hopefully. So James Alexander asks, is there anything I disagree with Dr. Russell Barkley about regarding ADHD? I know he disagreed with me, and I'm forgetting now which video I came out with. And I think he thinks I am, I think the question is how we're going to be defining ADHD in the future, and how far the spectrum stretches, and what we should be, how we should consider people who have executive function deficits that are completely, or that are coming from the context of depression or anxiety there. So thanks for being here. Glad to have all the good questions and try to answer them. And I will be back next week, same time. So stay healthy, stay happy, and have a good week in a crazy world.